morning. Thank you guys for joining us for Coffee with Cade. I am thrilled to have the one and only Dr. Mary Hinckley from the Reproductive Sciences Center of the San Francisco Bay Area. Dr. Hinckley, welcome.
Oh, thank you so much. It's nice to be here and nice to be able to get to see you again, even though, and now in this world, we're always using Zoom or some other video teleconference. So I'm not too tired of it to not want to speak with you today.
Oh, you just made my whole heart smile, and I look forward to seeing you and giving you a hug in person at some point in the future.
Yes.
So let's look forward to that. So Dr. Hinckley is going to be talking with us about something that's very, very important, single embryo transfer. So often when people think about fertility treatment, particularly those who may be paying out of pocket or who may have limited insurance, think, I want to get the most for my money. I would love to be a parent of twins or triplets. And full disclosure, I'm a triplet mom. And so they would go into their doctor and say, hey, give me everything. I've got 12 embryos, put them all in me. I can handle it. And what the American Society of Reproductive Medicine has said is it's better to transfer one. And so Dr. Hinckley is going to tell us why that's important and perhaps dispel some myths about single embryo transfer. So Dr. Hinckley, tell me all about it. Why?
Well, you raised some really good points, which is why not put more than one in? I get it. Patients, I've been doing this long enough that we were not super successful back in the day when we first started. And we did need to put more than one embryo in to try to help patients get a reasonable success rate. But what's happened in our field is we've completely improved. It's so great to hear for patients that struggle with infertility, is that we've actually made major advancements in how we do this. And so now you have to take the current data and listen to it and look at it and make decisions that are more appropriate with what that data shows. And that's why the ASRM changed their stance. And that's why many clinics actually were even doing this before the ASRM told us to, because we realized that when we were putting more than one embryo in, all of a sudden we were getting twins, sometimes triplets, and then we had a whole host of complications, which ultimately did not lead to that healthy, happy family that we were looking for getting. So, your situation, fabulous. The kiddos are doing great. But what people don't realize is that there are a lot of problems in pregnancy if you have multiples. Obviously, triplets more than twins, quads more than triplets. But there's pregnancy problems, preterm labor, placenta previa, placenta abruption, higher incidence of diabetes. There's also baby complications, prematurity, there can be hemorrhages in the brain, there can be problems with the stomach, the eyes, the ears. Things have not developed well enough. And then there can be problems just in the family. And that is just the stress of it all, the numbers of doctor appointments you have to go to, the cost. Some people say, oh, I want to have 2 children at once because it will save me money. But those of you that are moms of twins out there know that twins aren't always saving you money. You can't reuse the stroller. You have to get a double stroller. So there are problems that people don't know, or really they don't really weigh heavily. And what we've done now that the success rate is better is really try to educate people so that they know that, hey, listen, you've got a choice, and maybe the best choice is one at a time.
Okay, so there's a lot to unpack there. You just gave a lot of information. So tell me, what is the likelihood that a family or an individual will get pregnant with one embryo if they put just one back? And then what is the likelihood if they were to put 2 back?
Well, a lot of it depends on the quality of the embryo and whether or not the embryo has been tested. And then it depends on the mom's age, mostly just the moms, a little bit the dads. But in general, let's just take some overall statistics. If we put 1 back, the success rate, all comers might be around 55%. If we put 2 back, it might be closer to 70%. However, especially in that younger age, about half of the pregnancies would be twins. And again, while that may sound really good for some people, we know that the incidence of problems is so high. So you also have to look at what is the chance of a problem, and we have this really nice graph we use for patients. So when I see them, I'm often showing them a little graph here, and I say, but you've got to remember, if you have one baby, your chance of delivering premature is about 11%. If you have two twins, your chance of delivering prematurely is about 58%. And that also increases the risk of cerebral palsy, by 6 times. It increases the incidence of mortality, of the baby actually dying, because usually it's so premature, by somewhere around 5 times. So you've got a much greater risk for reward. So that's what we try to help people understand.
So it's the risk of having a multiple pregnancy with more than one baby versus a slightly higher chance of conceiving at all. So correct. It's kind of those two things. Now you mentioned some of this is dependent on the age of the mother, which we're really talking about the age of the eggs, because correct. Most women are born with the maximum number of eggs that they will ever have. They're never going to get, matter of fact, no one ever grows new eggs. We can adopt, we can donate, we can get other eggs from other places, but our bodies aren't going to produce new ones. Is that correct?
That is correct. Science is working really, really hard to help us try to do that, but we haven't gotten there yet.
So tell me, how does donor egg differ? How do the outcomes for single embryo transfer differ for those who use donor egg versus those who may use their own eggs?
Yes, hugely different. And actually in our practice, that's where we first started to implement the single embryo transfer policy. And a lot of us use the acronym ESET, elective single embryo transfer. So we started to do that for people who are using donors, because that's where our twin rate was so high. And we even offered a financial package. We said, if you let us put only one in and you don't get pregnant, we'll pay for your second transfer. And patients agreed to that. And very quickly, we had enough data to show them that by putting one in, they could have almost the same success rate. So the success rate only differed by about 5% if you were using donor eggs, and yet the twin rate was 50% if you didn't. So actually you had a better utilization of your embryos. You took better care of them by putting only one at a time, because ultimately you could get more babies that way, or at least more tries.
More tries, less, the downside is really reduced, and the upside is much better. So I know that things are different today than they were when I went through fertility treatment. Why is it that things are so much better now? And I understand, that depending on the age of the woman and whether or not the embryo has been screened for genetic abnormalities, but have there been changes in the process of IVF? Improvements in the way that embryologists kind of care for the embryos? What else has changed to make this difference?
So yes, you hit the nail on the head. Exactly. So probably one of the biggest changes has just been in embryo culture. So what happens in the IVF lab? And we know that because we can look at different clinics, and clinics that have really improved their IVF lab have really improved their overall take-home baby rate, and really improved their number of transfers that are elective single embryo transfers. So some of that has to do with the culture media, what the fluid that the embryo grows in. Some of it has to do with the air around the embryo, the balance of oxygen and nitrogen. Some of it has to do with the equipment. but probably the most important for at least our clinic had to do with being able to culture the embryos to the blastocyst stage. The blastocyst stage of development is day 5 or day 6 in some clinics, where the embryo has become much stronger. It has already segregated its cells so that some are going to be placenta and some are going to be baby. And we know that it's competent to do that. So there are probably twice as many embryos that will divide up to day 3. They'll become 8 cells. But to be able to make that jump, to activate the genome and start their own division, that embryo has to be able to do that to become a blastocyst. So if we can support the embryo well enough to get out to day 5 or 6, we can sort and find the embryos that are more likely to implant. We're not weeding out the bad ones. It's just the human body and the human embryo is only a certain amount are able to make it to that stage. So it's allowing us to be able to find those and preferentially put those in.
Well, that was actually going to be my question. So most people think, you know, when I have a monthly menstrual cycle, there's only ever one kind of egg that stands a chance at becoming fertilized, but doesn't it start, you know, with a larger number, and then you know, there's only one egg released, but don't a couple of them start to grow and mature? And then, will you tell me about that a little bit?
Yeah, absolutely. So every month, women have a certain number that are candidates for ovulation. Sort of, they've turned their resume in and they've said, pick me, pick me. But only one has enough receptors and responds to the amount of hormone that a woman's body makes to grow and mature and ovulate, except for in those rare chances when people get spontaneous, non-identical twins. But even when you ovulate that one, what seems to be perfect egg, and you have perfect sperm and perfect tubes and a perfect uterus, women only get pregnant about 20% of the time. And so many of those times, an embryo is actually formed, but it's not healthy enough to divide to the point of becoming a blastocyst and implanting. And those embryos would just dissolve in the woman's body. She would never see it. She wouldn't know about it. And then when it didn't implant, the body 2 weeks later would go through a menstrual period. So from that standpoint, it happens in the woman's body, but now we're able to see that happen in the incubator in a petri dish. And we just see that some of those embryos just can't make it, no matter how good your system is at supporting them.
So because there's associated with fertility treatment, and you're not tested that frequently when you're just having a, you know, regular period, menstrual cycle, unassisted conception, are some of those missed pregnancies what you would know now if you were going through fertility treatment as a chemical pregnancy, where you know, there is a pregnancy, but it was a non-viable pregnancy? Is that
Absolutely.
What it is, pregnancy?
Absolutely. And the better your pregnancy test is, the more often you can find that out. And so in research studies, that's how we know that, because we did very, very sensitive pregnancy tests to show that egg and sperm were meeting many more times than women would ever know. But the healthy ones are able to implant and keep growing. So that is what, you know, that blastocyst development is key. The other thing that has really transformed this field has been being able to do embryo testing for aneuploidies. Aneuploidies are chromosomal abnormalities that the vast majority of times do not allow an embryo to implant and grow long enough to be a healthy baby. So the majority of chromosomal abnormalities will miscarry. Some, like Down syndrome, there's a few others out there, some X and Y chromosome issues like Turner's or Klinefelter's, can result in a live birth, but most will not. And so that's the other thing, is that now that we're able to test those embryos, if we can find the ones that never would have implanted or would have miscarried early because they're chromosomally abnormal, again, we can sort them and put the good ones that are chromosomally normal first, preferentially bad.